Alright gang, so we're going to have a little discussion around the urgency to breathe. Now, we did talk about this in the tutorials, but for me, it took me a couple of goes of actually talking through it before this really landed for me, so I'm going to run through it with you one more time. So when we're talking about the urge to breathe, it's the area in the brain that actually forces us to draw breath. And when we're talking about the urge to breathe, we're talking about the physiological parameters that trigger that urge to breathe. Now, it might be surprising, but the urge to breathe is actually primarily being driven by our CO2 content in a healthy individual. So let's have a look at these two curves. Now, what you can see here, if we look at the hypercapnic ventilatory response curve on the left there with the yellow highlight, you can see that there's a very sharp incline pretty much as soon as we get past 40 pCO2. Now, that's actually a very tight range there. So I just want to point out here, our normal range in this subject, we refer to it as 35 to 45. But you can see 35 is quite flat. We haven't been triggered to draw breath yet. But once we hit 40, we're definitely getting the urge to breathe out that CO2 and get rid of it. So it's actually a little bit tighter range here, and you can see that the most accurate that you can get for a normal PCO2 would actually be 40 to 45 rather than the 35 to 45 that we have in our worksheets. And I just point this out because I might have seen a sneaky exam question that had something about this, so remember that one. Whereas when we come across to our hypoxic ventilatory response curve, we can see that that one takes a fair bit longer before it has an uptick. So in the blue highlight there, we have our normal range, which is 75 up to 100. And you can see that even at the lowest level, 75, there's still not really a great deal of an urge to breathe here. And it doesn't really kick in until we get below 60, maybe even around 50, 55. So our PO2 has to be drastically low before the lack of oxygen in our blood is going to trigger us to draw breath. Now, let's talk about the key points for our hypercapnic urge to breathe. So we want to make note that it is the primary ventilation driver in healthy individuals, and that urge to breathe is mainly driven by our central chemoreceptors, which are located in the brainstem, the medulla pons if you want to be extra specific, and it's actually monitoring our cerebrospinal fluid up there for pH. Now remember that carbon dioxide, when we have more carbon dioxide in the blood, it actually dissociates into hydrogen ions, and so when we think of CO2 increasing in the blood, we think of increasing acidity, which will drop our pH. So I'll say that again, CO2, as that increases, we think increasing acidity, which reduces pH. And the last thing that we want to mention here is that when our PaCO2 is high for an extended period of time, so this is what deep sea divers do when they're trying to increase their breath hold time, what they're doing is progressively reducing the sensitivity of that central chemoreceptor by exposing it to increased PCO2 over longer periods of time. And so when we see patients who have long-term or chronic lung conditions, this is what happens to them as well. They have a chronically elevated PCO2, and so that chemoreceptor becomes desensitized to a low pH in the blood, and so that urge to breathe is actually reduced. Now, in these patients, they're actually relying on hypoxic drive to breathe, which actually makes things worse because we said our hypoxic urge to breathe doesn't kick in until that oxygen is really drastically low and far outside its normal range, compared to our PCO2, which drives the urge to breathe really quite promptly, even before we're outside normal range. Whereas our hypoxic urge to breathe waits until we're far outside our normal range before triggering the urge to breathe. Now, this is important because in normal healthy individuals, we don't rely on hypoxic, but for people with chronic lung conditions, they are absolutely relying on their hypoxic urge to breathe. And of course, they are more prone to hypoventilation because of that. And so when you are treating these patients in hospital, if you put a chronic lung patient on oxygen therapy, by increasing their PO2 levels, you are actually reducing their urge to breathe. And so they will hypoventilate even more, which means they're not breathing off the CO2, which means that CO2 is increasing even more in their blood, which is increasing the acidity of their blood even more and reducing their pH even lower. So that can become quite a dangerous acidotic state if we as health professionals are not across this hypoxic urge to breathe and the impact of putting them on oxygen therapy. So for these individuals who are relying on hypoxic ventilatory drive, they are actually using more of the peripheral chemoreceptors located in the aortic and carotid bodies. The carotid body ones are the most important in humans, and those ones are of course monitoring the blood pH and the actual partial pressure of gases. And that is our hypercapnic versus our hypoxic urge to breathe. Okay, you guys have got this.